Introducing our first speaker. Dr. Robert Valek is a professor of pharmacy, epidemiology, and family medicine at the CU Schools of Pharmacy, Public Health, and Medicine. For the past 2 years, Dr. Valek has been coordinating center director of the Colorado Consortium for Prescription Drug Abuse, a statewide coalition developing collaborative solutions to address this problem in Colorado. Please welcome Dr. Rob Valek.
Thanks, Ben. Thanks, Kathy. And thanks to all of you for coming, and both here and at the remote sites. It's a great pleasure to be able to come and speak with you today and share some information about a problem that this audience, admittedly probably knows a lot more about than most. But still, even with knowing about the problem, hopefully there's some new information and some things that maybe you hadn't yet heard that can still be useful, and pose some areas for you to think about where you may be able to have an impact on it. So by way of disclosure, I don't have any financial relationships or interests with any manufacturers of opioids or anything of that nature, so I don't have any financial interests to disclose on this topic. What I'd like to try to accomplish in 50 minutes, it's tough, but try to accomplish 4 things. First is to describe a little bit about the scope of the prescription drug abuse problem, both in the U.S. and here in Colorado. Secondly, discuss some of the factors contributing to the growth in prescription drug abuse. Third, to highlight some of the initiatives and programs, both at the federal level and in other states. And then fourth is to detail what we're doing about it here in Colorado and some of the things that you as a pharmacist can do to help. So with this crowd, I probably wouldn't get this question, but surprisingly enough, in the last couple of years, I still get this question from a lot of people when we go and talk to them about the prescription drug abuse problem, or go to a foundation, a health-related foundation, and you would think, well, they'll have a really good understanding of this. And some of them still ask some variation of this question. So what's the big deal? Isn't this just a few homeless people that are, that overdose and die under a bridge, and it's only 3 or 4 a year? So, what's the big? This is not a big social problem, right? And I get that kind of and I still shake my head thinking, you have no idea. And what I try to tell them are things like this. If you just start with mortality, just the number of deaths, and it's only the starting point. In 2010, there were 38,329 people who died from a drug overdose in the U.S. That's one more frequently than every 15 minutes dying. Nearly 60% of those involve prescription drugs. So myth number 1 is this is all illicit drugs. It's heroin, it's cocaine, it's crack, it's whatever that people are dying from. Not true. Myth number 2 is that among the prescription drugs, it's not the prescription opioids. It is. 75% of those are prescription opioids that are responsible. So it's about half of all of it. It's roughly 18 to 19,000. Most recent data from 2 years ago now suggest it might be as high as between 21 and 22,000 opioid-related overdose deaths in the United States in a single year. So that would be, 7 9/11s every year. And if that happened as far as, with something horrible like 9/11, but if it happened 7 times a year, I can only imagine the changes we would make in terms of travel and security and all that kind of stuff. But we don't seem to be, nearly as aware of this one. It's a very silent epidemic. In Colorado, those drug overdose deaths range anywhere from 250 to 550 a year. Our most recent data for 2013, where the number is 295 opioid-related overdose deaths. Since 2003, in about the last decade, more overdose deaths have involved opioids than both heroin and cocaine combined. Again, people think it's the latter, and it's really the former. And rates of misuse and overdose death are highest among men, persons aged 20 to 64, non-Hispanic whites, and those in poor and rural areas. Though, with that said, it really is an epidemic that cuts across all demographic, racial, ethnic, gender, or income lines. It really does not matter. You sometimes see the overdose deaths happening in middle-aged people simply because it's the life course of addiction. Generally starts younger, progresses, gets worse, and gets to the point of abuse, and that tends to peak in terms of the overdose deaths in middle age. But it's really not a function of middle-aged people being at higher risk than any other age group. The drugs work the same no matter what your age is. In terms of drug overdose mortality in the U.S., some people ask, how do we relate to the rest of the country? How bad is it here in Colorado? And I'll try to use pointer. Colorado here, in the middle, you can see our rate is between 10 and 15 overdose deaths per 100,000 population per year. And it's worse with the darker colors. Kentucky and West Virginia, to some extent in Florida, New Mexico and Nevada around us, so there's a problem, sort of in the intermountain states, is typical. But we are about middle of the pack in terms of drug overdose mortality. Some people say that's good. We're not one of the worst. Other folks argue that everybody's not doing so well. So we're a little bit better among everybody who's not doing so well, and I don't know how comforting that is. That's kind of how I interpret it. It's still bad for all of us. Those trends over the years, as I mentioned, the problem has tripled. Back in the late 70s, when the earliest data that I could find were available, about 4 per 100,000 population were dying from prescription drug overdoses. And that doubled in 20 years to the late 90s to about 8. And then in the most recent years, starting in 2005, but now to 2010 and on, it's about 12.7, 12.5, 12.7 per 100,000 per year. So that's the rate, how it has tripled over the last couple of decades. And people wonder, how big is 12.7? That a lot. Put that in context with some other number that I can understand. You look over at motor vehicle deaths at about 9.5 per 100,000 per year, and drug overdose deaths being at 12.7 per 100,000 per year. This problem is worse than traffic accident deaths. And this is true now in most states. You can see there's a few states where that's not true as of 2010, but the drug overdose deaths being greater than the motor vehicle accident deaths is now the rule rather than the exception. And this is illustrated in this particular graph, that the motor vehicle traffic deaths have been steadily declining over the last 30 years due to a number of factors, highway safety and airbags and improvements in automobile safety and seatbelt laws, and we've paid a lot of attention to that, which is good. But things like firearm deaths and drug poisoning deaths are now of great concern. As you can see, over the last 20 years, those have been increasing sharply and now are more prominent than either of those others. This is what's gotten the attention back in the early 2000s when that number started to exceed these other numbers. Policymakers start to listen when that starts to happen. It's a very compelling thing. Same thing happened here in Colorado. And of those prescription overdose deaths, as I mentioned, the opioids are responsible for the vast majority of them. Nearly 17,000 per year are opioid-related overdose alone. Other drugs that are implicated include benzos, but most of those are concomitant use. The vast majority of opioid overdose deaths involve both an opioid, a benzodiazepine, and alcohol at the same time at time of death. So that's by far the most common. All the other drugs are much lower in terms of their contributions. And then you can see stuff, some of the other drugs that people think are big problems, hallucinogens, and some of the others are very, very far down the road in terms of overdose deaths. But that's really only the tip of the iceberg. People talk about mortality. It's the most important outcome in the sense. It's the final outcome. But the impact of this thing is much greater. For every one of those 20,000 or so deaths in the U.S., there are 10 treatment admissions for abuse. There are 32 emergency department visits for misuse or abuse as the primary diagnosis. So this isn't somebody coming in because they had a heart attack secondary to that or got in a car wreck secondary to that. This is the primary reason for the admission. So that's a lot, 32 for every one of those 20,000. There are also 130 people who meet medical criteria for substance use disorder, who would be diagnosable with substance use disorder. And very alarmingly, for every one of those deaths, there are 825 people who self-report non-medical use of opioids within the last year. And this is just, again, probably an underestimate. We think by about, it's about a third would be the most accurate for people in terms of self-reporting biases. So it's probably more like 2,500 people per, so if you do the math, 20,000 times 2,500, and my little calculator blows up at that point, and it becomes so prevalent that we're talking probably in the neighborhood anywhere between 1 in 10 and 3 in 10 Americans self-report non-medical use of opioid within a year. So it's just a huge problem. The cost to the economy is substantial. The most recent published studies are neither recent, nor do I think they're very good in terms of being inclusive, but I try to find the best available data. A study from 2006 reported the total cost in 2006 dollars in the mid $50 billion range, a lot of it being lost productivity, but also medical complications and increased criminal justice costs. I saw some more recent data from the health insurance industry, the Health Insurance Institute of America, who they're very good at counting, actuarially speaking, what insurers pay out for various things on the medical and on the productivity kind of side, and the estimates are tenfold. The estimate now is somewhere between $600 and $650 billion a year in the United States alone for the impact of this problem, far greater than we ever thought. And I tend to trust the insurance companies to know how much money is being spent more than the academics like myself. I don't think we do nearly as good a job as counting and actuarially forecasting things like the insurers do, because they know what they're doing with their money. So people say, all right, if the problem is this big, then we should get everybody into treatment, right? All those people that are self-reporting non-medical use and all those people that meet substance use disorder criteria, get them into treatment. We estimate that there are at least 21.6 million Americans that need and are ready for treatment. But we have capacity for treating about 10% of them. And that's our current treatment capacity. As this crowd probably knows, if you try to refer somebody to substance use treatment, whether it's pain management, addiction management, or substance abuse treatment, extremely hard to get them into treatment because of capacity issues. We simply don't have beds to try to do inpatient intensive treatment for everybody. So it's one big problem. So we would just treat people on an outpatient basis with medication-assisted therapy. Suboxone, methadone is a viable, effective strategy for at least maintaining people effectively so they can lead their lives and not spiral out of control and die. But there's a huge problem with the number of physicians who have chosen to go through the process of being certified to prescribe methadone or Suboxone. And in Colorado, it's fewer than 3 per 100,000 population physicians that are currently certified to provide Suboxone or methadone treatment. I know many of them personally because I've made this tour around the state with talking like this and talking to those physicians, and most of them are either full in terms of capacity for taking any more patients, their panels are full, or they're simply getting out of the business because it's so difficult to do this, or they're just saying, look, I've been doing this for 40 years, I'm not doing it anymore, I'm retiring, I keep my certification, but really I'm retiring. So this number is believed to be down in the 1 range for Colorado, about 1 per 100,000. So we don't have capacity to do it on an inpatient basis, but the good news is that there's more bad news. We don't have capacity to do it on an outpatient basis either. So I try to convince you that if it hasn't already, that you didn't know that we're in kind of a mess. So how did we get in this mess? First off, this is not a talk on the neurobiology of addiction. It's very complicated. Let's leave it at that. But it's a complex interaction between biological and genetic factors, environmental factors, factors related to the drug itself, brain mechanisms for addiction which are not well understood yet, and how all those are mediated or moderated by various other concerns. Then this all leads to a complex, both physiological and behavioral construct of addiction. Addiction is much more than simply having high tolerance to an opioid or having withdrawal upon removal. It also deals with the behaviors that are involved and how people end up being affected behaviorally. So it's a really complex problem that we're trying to study, and unfortunately we don't understand very well. The one thing we can point to as a virtual certainty is that prescription drug, in particular opioid availability, has gone up over the last 20 years. When I came out of pharmacy school way back in, whatever that was, when I came out of pharmacy, it's not important when I came out of pharmacy school. But what is clear is that back then, in the early to mid 90s, there was a fair amount of opioid being dispensed already. As pharmacists, we know what morphine equivalents are. There was about 96 morphine milligram equivalents dispensed per person in the U.S. annually in 1997. By 2007, that had gone up sixfold to 700 morphine milligram equivalents per person in the U.S. each year being dispensed at retail. And that amount is enough for every American to have a Vicodin around the clock, every 4 hours around the clock for 3 weeks. Everyone. So it's staggering. 200. I saw a statistic the other day. I just haven't worked it into the slides yet because I have to turn my slides in, more than the day before, which is unfortunate because I do most of my work the day before. But if I had been able to work it in, there's 296 million prescriptions dispensed for opioids last year in the U.S. 300 million. That's enough for every American to have an opioid prescription. And that's a corresponding statistic. Enough for everyone to be on an opioid, which seems a little high to me. Everybody? I can see a lot, but everybody? Seems a lot. So why this increase? There's a lot of factors. One of them is, when I came out of pharmacy school, the big mantras were pain is underdiagnosed, undertreated, not being recognized. It's barbaric. We need to be able to provide adequate pain relief for people who are in legitimate pain and are not being treated. And that still exists to some extent and in certain pockets. But that was the big push then. Now it has gotten to the point where, it's just recognized as part of medical practice. To treat pain is the fifth vital sign. Or to have the JCO measure for assessing people's pain and having a plan to address people's pain. JCO did not invent or use the language, pain is the fifth vital sign. People sometimes link those, but it's not true. JCO does say you should assess patient's pain and have a plan to address it. There's also the hospital discharge surveys and patient satisfaction surveys. Many of them, if not all of them, contain questions on adequacy of pain treatment. How well was your pain addressed? How well was your pain treated? And those scores are often tied to quality metrics for health plans, for hospitals, for providers. And so they want to do a very good job of addressing people's pain. But it also gives direct incentives for them to want to have their scores be higher to give out more pain relievers so that people will leave with their pain addressed. And so the incentive is to err on the side of making sure you overtreat pain. And that's contributing to the problem. There's also no denying that drug company advertising and promotion is effective. We know that. And the drug companies are very good at it and have continued to push, hey, various indications and that there are appropriate uses. But, with that comes an increased awareness about availability of things, and they do have an incentive, obviously, to drive sales. It's also well known that practitioners are not well trained in opioid pharmacology and addiction. Even among this audience, we're the best trained people that there are in terms of pharmacology, period. But we still don't do enough, even in the very best of programs, which we think we are one of them, in terms of teaching about opioid pharmacology, addiction, withdrawal, all the things that are involved in drugs that are so commonly used. So it's still a knowledge deficit. Certainly that's true among prescribers, and the more complicated the case gets, if somebody gets into more advanced, difficult pain management or transitioning over into the possibility of addiction, most providers just simply don't have any training whatsoever in that, and they're just trying to fly along and learn on the job to treat these very complex conditions. The drugs are extremely powerful and highly addictive if not used properly. Again, to this crowd, that's easy to understand. Most people have no idea how addictive opioids are, especially when you get to certain thresholds of morphine equivalents per day and certain durations of time. You get to 60 or 90 days of use at a certain threshold of 50 morphine equivalents or more. Your likelihood goes up 4-fold, 8-fold, 12-fold for having an overdose and dying from it. So it's just a remarkable uptick in the risk when you get out about 60 days, certainly by 90. So chronic use is a very risky proposition. And then, of course, there's a strong black market for these drugs. And in people, when they're addicted, it's also have a direct incentive and desire to continue to feed that problem. So there's a lot of scamming, doctor shopping, pharmacy shopping, and a strong black market for opioids. It's much more expensive to try to get an OxyContin on the street than it is to get black tar heroin. About $20 to $30 for one dose of black tar heroin, and about $80 for one 80 milligram OxyContin on the street. It's about $1 a milligram. So it's the direct, the economics of it. You do the math. It's a lot cheaper to go over to heroin for people, and that's why we're seeing an uptick in heroin use, distribution, and overdose deaths as well. And not surprisingly, where the opioids go, the states that have higher sales and use rates tend to have the higher overdose deaths rates. The use of opioids are the little circles, and the larger the circle, the larger the amount of opioid per capita going into that state. And the darker the state shading is, the higher rate of overdose deaths. So you see, like in Kentucky and states like that have had a known issue for 30, 40 years and have been trying to do a lot of things to address the problem, they have both. And that's generally true. Smaller dot, lighter shading. That's what you tend to see. Same thing with as the sales go up in the blue line, opioid deaths go up in the red line, and treatment admissions go up in the sort of brownish orange line. My colors are right. So as I mentioned, Colorado is about the middle of the pack in terms of the amount of opioid that goes into the state. We were 37th in the U.S. In 2010, but we were number 2 in the U.S. in 2010 in terms of self-reported non-medical use of opioids. So about 6% of the entire population in Colorado in 2010 reported non-medical use of an opioid. And we think, again, it's probably about triple, probably about 1 in 5 Coloradans are non-medically using. And this got the attention of the governor here in Colorado and said, we want to be number 1 in a lot of things, but this is not it. So, we need to do something about it. So it's part of the reason why we're doing what we're doing. As of 2012, that number was 16, and I just saw the 2013 data. It takes always about a year and a half to see the data, but it looked like we were making some progress. We're now back to number 12. So it's, we think we're making some progress, but this is a very strong uphill sled that we're trying to do. So how does this problem start? We always figure, all right, if we're in this mess, which I think I've probably convinced you that we're in a mess, there's a lot of reasons we're in this mess, fine. How do we do something about it, and where does it start so we can attack it? So most often, good luck with me here. I made the bold play of trying to put videos into my presentation. This is most often how it starts.
Who else has been taking your prescriptions? Keep your medicine and your family safe and secure. Mind your meds. To learn how, visit the partnership at drug.
So as you can see, this is the most common place that people start misusing and abusing prescription opioids is from friends and relatives from their medicine cabinets. More than 2/3. This number vacillates from about 68 to 75%. So between 2/3 and 3/4 report this is how they start. They get stuff from somebody's leftover Vicodin in the medicine cabinet. And so this is where we think we need to start is with the security and safe storage and disposal of what we've already got. Because most people start there, then they progress to going to one or more doctors when they go to their house, their neighbor's house, their grandma's house, friend's house, and rifle through medicine cabinets. And this is exactly what people report going into treatment, that's where they start. And when that all gets exhausted, have to start going to doctors to try to do this. So they go to the typical things, go to as many doctors as possible, go to emergency rooms on Friday night or Saturday night, do all the things you would expect. As pharmacists, we know this, someone coming in at 5:45 on a Friday, so you can't contact the doctor. I've been in pharmacies. So I totally understand how this happens and what you can see the potential red flags, but this is exactly what happens. And then people move to, when they get cut off there, to heroin and to street drugs. But it's not the other way around. People tend to think it's the other way around. People start with hard drugs on the street and then start to access the prescription stuff. Not true. The majority of heroin users in the past year, the vast majority of them report anywhere from 65 to 75, and in some cases 80% of those heroin users that started with opioid pain relievers before heroin. So it's a sequencing thing, but it's people starting in the medicine cabinet, eventually ending up on heroin. So how does the problem end when people get started in that spiral that we talked about? And you see some examples. Unfortunately, it often ends like this.
Full of energy.
Restful. Right.
Play very much. Fun.
I didn't don't sure. I would much rather like this. That but that shape like David.
The worst consequence is death. Other consequences are, like Aaron, got alive, but still. You also lose all of your. But did you ever think anything bad that happened taking prescription pills?
Help save kids from prescription drug abuse. Secure your medications at top. Visit drugfree.org.
So I'll put in a shameless plug for the folks at the partnership for partnership at drugfree.org, which is now rebranded as Rise Above Colorado. Kent McClendon and the group there do tremendous work, and they produced that video, which is very powerful, a real story about someone in California, in Southern California. But this is common around the country. Again, the 20,000 deaths are extremely important, but as we saw with the tip of the iceberg, there's many, many more cases like this that impact families and the loss of, productive, viable, productive person that just completely has their life ruined. And it's the tragedies are really innumerable. So it's very important that we try to address this. So what are we doing about it? I didn't create this graphic because it would have taken me half of my life to try to produce something like this. But you can see my black and white slides and bullet points. That's all I can do. But there are various things going on at the level of everything upstream from manufacturing and transport. There are still instances where OxyContin trucks get knocked off. You wouldn't think this is true, but it is. So facilities have to be disguised where the drugs are produced. Shipments have to leave in the middle of the night under protection from state patrol to transport the drugs, because black marketeers know exactly where those things are and when the trucks leave and all of that stuff. It's just like trying to protect the president when they're flying in. Things have to practically be shut down to transport OxyContin around because it's very lucrative if you can knock off one 18-wheeler full of OxyContin. They estimate it could be a $50 million truck for somebody on the street. So it's a big deal. So everything from upstream protection of the supply to things like, in terms of the medical system where you would see things, we know that pill mills still exist. They're less frequent, but in the last 2 years, 2 of them have been shut down in Colorado that were large. A couple of them that were smaller scale, but 2 very large pill mill operations were shut down. A couple of pharmacists are now in jail, serving 12 to 20, and the physicians and pharmacists involved have, of course, lost their licenses and are going to prison for long periods of time. But this still does happen. One of them was in Lakewood, Colorado. One of them was in Buena Vista, Colorado. This happens, and the Attorney General and the Deputy AG, you'll see them in the news when they announce these sorts of prosecutions. So they still happen. There's also, issues with problematic prescribing. We know that not all docs, are as vigilant as maybe they could be and know as much as they could. There's issues in hospitals and emergency departments for people drug seeking, and then it's very difficult for physicians there to determine legitimate pain from drug seeking in a very, very short visit when they've got a short amount of time and an ER piled full of people, and it's very difficult to determine, legitimacy of pain. So there's problems there. There's problems, obviously, same thing at pharmacies. You have the same difficulty. How do you know when someone comes up if this prescription looks patently illegitimate? They change 40 OxyContin to 4,000. It's pretty obvious, but other than that, it's difficult to say if somebody gets 30 OxyContin or 50 Vicodin or whatever. Very hard to know. PDMP helps, but it's still very difficult to know about legitimate pain treatment and what's illegitimate. Extremely tough. And then insurers are obviously trying to do what they can, and what we're trying to do is identify people at high risk for overdose and generally educating the public and intervening, if you will, with the public for better educational efforts to be aware of this problem. So there's stuff going on at various levels. At the federal level, the CDC has identified prescription drug abuse as one of the top 4 epidemics facing the country. So when the elevation of that topic should hopefully get people more aware and give them the understanding of the gravity of it. When we're talking about heart disease, cancer, HIV, prescription drug abuse, it's one of those. It's not something that affects a very small number of people, and we shouldn't be paying much attention to it. It's a top 4 epidemic. The FDA is doing a lot more. They're requiring pharmaceutical companies to create REMS programs and abuse deterrent formulations. They've come right out and said, we're not going to approve anything anymore that isn't abuse deterrent. So good luck with getting anything through that isn't. That's a step in the right direction. They're requiring a lot more in terms of risk management and post-marketing surveillance for problems. That's a step in the right direction. But, their job is to approve things that have legitimate medical use and that are safe and effective for treating whatever conditions. They're not in the job of regulating, things beyond that. The DEA has some purview, and they've done certain things in the last year. They rescheduled tramadol last year to Schedule 4 from being legend. They rescheduled hydrocodone combination products up to Schedule 2, which you're aware of. And that's depending on who you listen to, it's probably a very good thing, and it's probably also a very bad thing for different reasons. They've also created new rules, which you're aware of, for allowing pharmacies, long-term care facilities, physicians to register as reverse distributors and take back unused or expired meds. But they are now not doing any more of the national take-back days. The last one of them, the 9th one, was last October, and they aren't doing them anymore. So now we've got an issue, obviously Colorado, as other states do, that how do we get rid of stuff? We've been trying to condition people to bring them back, and now we have a problem if we don't have really viable mechanisms for take-back and disposal of medications. So it's a top issue for us right now. In other states, a lot of things are happening at the policy level. Tougher laws for pill mills and doctor shopping with much more severe penalties, more strict physical exam requirements. Many states, especially frontier and rural states like the Northern Plains, Wyoming, Montana, the Dakotas, Idaho, have much looser laws about whether physicians have to physically examine a patient because there can be great distances and great burden for patients to travel. So many times, doctors never see a patient and prescribe for them and never have physically examined them. And those laws are being tightened up because obviously now we have a problem on the other hand, when if you don't, now how can you really assess somebody's pain and function and all of those things you need to be assessing without actually seeing them? There's tamper-resistant form requirements that I mentioned, quantity limits, which we are aware of here in Colorado from, for example, our Medicaid program has quantity limits on short-acting opioids. Some states are doing that. Some insurers are doing that, not just Medicaid. So that's a payer side issue. For patient ID requirements, Colorado does not have one as far as state law requiring a patient give you a positive identification to pick up an opioid. Most pharmacies do that anyway, which I think is great. But it's not a state law. There is a state law for showing your ID for getting Sudafed. There is not a state law for showing your ID to get hydrocodone or oxycodone. To me, that seems like, well, I understand the meth problem, and I'm not saying that isn't a problem, but there aren't 20,000 people a year dying from meth overdoses or whatever in a year, and we moved very quickly to putting Sudafed behind the counter and requiring an ID. And we're just no more strict with OxyContin than that. Naloxone laws are moving forward, which is good. Naloxone is a nearly universally effective drug for reversing overdoses. And first, now we have a immunity from prosecution law in Colorado now. So if someone is basically a Good Samaritan law, someone may call 911, and even if they possess small quantities or are using small quantities of illicit substances, they will not be prosecuted for their possession or use if they call for someone who has overdosed. It's been a disincentive, obviously, if several people are using in a single place and one person overdoses, no one else has wanted to call for fear of being prosecuted. We also have naloxone laws that a physician can now prescribe for anyone. If you say, I know a neighbor or a loved one or whatever, a friend of mine is a user, I can get a naloxone prescription for me to carry a naloxone rescue kit and have that available in the event that other person has a problem. And that's novel because most prescriptions are only prescribed for the person who would be using them. So that required legal change, which we have. And currently there's a bill working its way through that cleared the Senate and is now in the House to create naloxone standing orders. So that if a pharmacist and a physician want to enter into an agreement to have standing orders, or the Harm Reduction Action Center or different facilities where physicians may not be present 24/7, 365, but people who might need access to naloxone are present all the time, that standing orders could be created so that those places could have access to and dispense those naloxone rescue kits. So those are also important. And then you've seen over the last year or so our PDMP program having changes made with push reporting and mandatory registration and the various things that we're doing, daily uploading of data, all of that stuff, we believe was necessary to bring our PDMP to the level of national standards. So we've made a lot of changes with our system in the last year or so. The other thing that's really happened here in Colorado is, like I said, when the governor caught wind of we're number 2, didn't like that, tapped the shoulder of one of his aides at the time, Kelly Perez, and told Kelly, you need to go around and start talking to people around Colorado and see what we can do about this, because we do not like being number 2. We want to be number 50 on this one. So we created what's called the Colorado Plan to Reduce Prescription Drug Abuse. And there were a lot of people who were convened, a couple hundred folks from different state agencies, professional organizations, treatment facilities, law enforcement, patient advocacy organizations, health and human service, all players that we could identify were invited to the table to help create this plan, with the goal of reducing that 6% rate that we had for self-reported non-medical use down to 2.5% by 2016. It's a very ambitious goal to think we can move things that quickly, but that's what the governor's, he was the one to set the bar. We told him how bad it was, and he said, here's how far I want you to try to go in 2 years. So it's difficult. We think we're making progress. We may not hit this mark in 2 years, but we're going to do everything we can to try to do that. And to do so, we've created a plan that addresses several key areas: provider and prescriber education, improving our PDMP, making recommendations and improving access to safe disposal, increasing public awareness about the problem, and doing a better job of measuring how big it is, because the data are from little pieces all over the place. We're trying to create better indicators for how big this problem is and to measure the progress that we're making, so we're not just seeing whatever we're doing is wasting our time. We want to see what we're doing is making an impact. So we're working on all of these different areas to do that. One big example of this, the public awareness issue. Our public awareness campaign will launch on Tuesday, the 24th, at 10 o'clock in the morning. Watch the news channels on Tuesday afternoon or evening, and you'll see this public awareness campaign that's going to be focusing on our 3 pillars of safe use, safe storage, and safe disposal. And we'll have several partners. Some of them are in the room here that are helping us with this, so they'll be given due credit for helping us, but it's going to be a statewide effort to try to do public education on this topic. So you'll see that coming. What can you do as a pharmacist? I'd like to focus the last few minutes on things that I think any pharmacist could do to try to help impact it. 6 things I think you can do. And, each of them is, I think, relatively straightforward enough. Educate yourself, educate your patients, use the PDMP, be aware of best practices, use technology and innovate, and then get involved in some way at the larger level. Because again, you can't solve this on your own. But it's not going to be 10 people that solve this thing either. You can't leave it to, somebody's working on it. Everybody needs to grab a shovel. No pun intended with the weather coming in. But everybody needs to grab a shovel and lift 1 scoop of dirt on this thing, or we don't solve it. It's just impossible. So everybody needs to help. So first, educate yourself. First, you need to educate yourself on the pathophysiology of pain. So yes, back to pharmacy school, back to CE school. You need to learn about pathophys and the types and mechanisms of pain, because neuropathic pain and nociceptive pain and traumatic pain are different. They respond differently to different mechanisms of treatment. Neuropathic pain treatments are very different from nociceptive pain treatments. And it's not just throw an opioid at everything. They're not equally effective. They are effective to some degree, but they're not equally effective. So learn about those things. Second, learn about the pharmacologic and non-pharmacologic treatment options. Not the only thing that we throw drugs at it. There's other mechanisms for physical therapy, acupuncture, various forms of, even talk therapy to deal with people in pain that are also depressed, that can improve people's depression, which coexists with pain most of the time. And that helps people's perceptions of their pain when their depression is better. And it's hard to tell sometimes. Is my pain making me depressed, or is my depression making me in more pain? Probably yes and yes. But if we address the one, it helps the other. So be aware of those things. Within the pharmacologic realm, understand the place in therapy of nonsteroidals, other drugs, opioids, how to dose them properly, how to get people, crossed over to if they need to rotate opioids if they're doing long-term therapy. Brush up on your opioid pharmacology. Learn about treatment goal setting and mutual treatment goal setting. Talk more with patients about their expectations for their pain relief. Don't just hand out the opioid and say, here you go, you're going to feel better. Try to help educate them that the best they can expect is if they're at a 9 on a visual analog scale of pain, the best they can expect is to get down to about a 6. Opioids are maximally effective at about 35% visual analog scale pain reduction. That's it. They will not remove your pain or get you down from a 9 to a 1. Get you from a 9 to a 6, which is good, but don't expect that this is going to completely remove your pain. People tend to think that. I take this pill, why am I still hurting? No, they don't work that way. And nothing works that way unless we can physically solve a problem that's physically generated, fixing your back or whatever. So you have to try to be realistic. And patients, when they're dealt with this way, studies have shown that when patients have realistic expectations for the drug therapy, they report much higher levels of satisfaction, even if it's only partial response. So a lot of our job and our opportunity is to educate patients this way, not just how to take it and when to take it with food, that's important, but expectations, and having those reasonable expectations. And finally, monitoring patients for pain and function. We're trying to move away from pain just being a number. It's important to know what the number is if they say it's 9. But, for me, if I stub my toe, getting off the podium today, I'm going to say my toe hurts like a 9 because I'm a wuss, so I'm going to always say it's a 9. And, just ask my kids, Dad, when you have a cold, you're the worst patient ever, because you can't take anything. Where's Dad? I'm about to cry. But other people, they've got a broken arm and they say it's about a 2. So there's issues with measuring pain on a visual analog 1 to 10 scale. We should be measuring people's function. What can you do or what can you not do? That's also equally important. So be aware of that, and that's what we should be treating people to, is pain and function. Then take these things and use them to educate your patients. The first few you can apply directly. The last one, we should be focusing not only on safe use, as I said, here's how you use this drug safely, which is our usual process as pharmacists, but also how do you store them safely and dispose of them safely? Because 68% of people start by stealing from the medicine cabinet of someone else. We need to make people aware of that. Got to tell people that when you dispense opioids. You need to secure these things. You wouldn't walk home with a bag of money and drop it on the counter, or a box of bullets and set them on the counter. You just wouldn't do it. You would lock them up, put them in the bank, put them in a vault, put them in a safe. We need to treat these things the same way. So educate your patients about that. Third, use the PDMP regularly. Many places now use this as a matter of course. In certain pharmacies, it's a matter of policy. So it's not it's just this, and I think it's a very positive development. Pharmacists, by the way, in Colorado, we kick ass as far as checking the PDMP. The vast majority of all the queries made to the PDMP, each month it's about 150,000 queries are made. About 110,000 of those come from pharmacists. So I think we're doing a great job, but we should be doing what we're doing. Check every time. Be aware. So that's important. And there's improvements being made to the system. We all know the system is not perfect. Believe me, Dora hears it all the time, that it's not perfect, needs to be better, needs to be faster, needs to be simpler, all of those things. And they're working to improve the interface continuously and work with the vendor to request changes. And, Dora is aware and doing what they can. Next, be aware of best practices. And there's a lot of information out there about how to treat pain and how to monitor people long term. First, as I mentioned, we should be doing pain and function assessment on an ongoing basis. Here's an opportunity for pharmacists to do things, to help monitor patients for their pain and function at each visit. And if you can offer that service and offer that level of attention to your patients and be able to report that back to doctors, all of a sudden we've added value. Everywhere that you can add value, there is going to be job security, and there's going to be a potential for you having a better position in your careers by adding value. That's what I always tell our students. It's whatever you do, add value somewhere, you will have jobs. And there'll be a strong need for it. Do risk assessment and stratification. It's considered best practice based on either someone's family history and opioid risk coming in the door at the start of pain treatment, or by the level of dosing. Many places have gone to 50 and 100 morphine milliequivalents. Some are 60 and 120, but depending on your thresholds, I adopt the 50 and 100, and there's good evidence to support it, that people's risk jumps when you get to 50 morphine equivalents per day, and it jumps again at 100. So put people, as like I tell, I'm an epidemiologist, so I count people and put them in buckets. So put people in buckets and put them in the low risk bucket, the medium risk bucket, or the high risk bucket, and treat them accordingly with more and more attention to monitoring and things that you need to do to make sure that they don't have a bad outcome. Again, monitor pain, function, usage, and risk. Those are the 4 things we should be monitoring, not just usage, which is what we're used to doing. How many tablets are they getting? That's one component, but we need to measure 4 things. Everybody should be getting urine drug screening if they're going to be using opioids more than 3 months. And that's just considered now universally recommended. And this is to make sure that they're taking what we expect that they're taking, and they should have the drug and the metabolite in the urine. And if they don't, there's a problem. And they shouldn't have other things that we're not expecting in the urine, because if they do, that's a problem. So we should be aware, and if we're not aware, how can we be determining what the effective treatments are and which ones are having the effect on the outcome? And to do pharmacotherapy rationally, we need to know those things. We should be using provider-patient agreements to, again, generate mutually defined expectations for how pain is going to be managed. Patients do better. Not only is it a CYA mechanism for providers, which to some extent it is, but that's fine, that we need to document what we're doing and be sure that we're covering ourselves. But patients do better when these things are mutually agreed upon and the patient has had a role in making that decision and both the provider and the patient agree that this is how we're going to do it. Things go better. So it's not just that exercise of CYA. And then reevaluate chronic use at 90-day intervals. Shouldn't put someone on opioids chronically and expect things to just continue along perfectly at the same level for years on end. I consult on a lot of cases legally where patients have been on opioids for 5, 7, 8, 12 years. And people don't see the gradual escalation. Don't think they have to check the PDMP anymore because the patient is stable for a year. So I don't really need to check it anymore. Not true. Don't think that even if somebody's chronic pain patient that you've been seeing in your pharmacy for a long time, back pain, same dose, that they can't go off the rails at any time. Especially if they're at more than 100 morphine equivalents per day. They are this close to going off the rails at any time. So be aware of it. Next thing you can do is use technology and innovate. And I'm sure you've heard this, there's an app for that. Well, yes, there is. There's apps for all kinds of things. There's even an app for opioid prescribing and monitoring called Opioid Safe. Found this, that it basically is a way for doctors to put patients into this system that does all this monitoring of them through an iPhone app. Their pain scores go in, their function scores go in every couple of days, they report side effects, whatever, and it calculates the morphine equivalents for them, it checks the PDMP for them. All the doc has to do is get a patient started, and they can do all these things that are recommended that they do and using this app. And it generates the patient-provider agreement. You can look it up, and it's really pretty cool. But it's none of it is really technologically that sophisticated. It's just sort of putting things together into an app, which is being done. So there's opportunities to use things that aren't incredibly hard to figure out. Just use them and figure out how to incorporate them into your practice. And lastly, you can get involved at the larger level, at the state level. We have what's called the Colorado Consortium for Prescription Drug Abuse Prevention. It was the brainchild of the governor and Kelly Perez and some folks that were doing this strategic planning. Decided a couple of years ago, well, what should we do now that we have this strategic plan? This is great, but who do we hand it to try to carry it forward? And there was a lot of discussion. Maybe it's DORA. Maybe it should be a regulatory thing. Some people said, no, it shouldn't be a regulatory thing. Maybe it should go over to public health. Maybe it should go to the attorney general, and it should be kind of a policing activity. That scared a lot of people. Maybe it should be a behavioral health issue, Office of Behavioral Health, which certainly each one of those agencies has a role in this. But it was felt that not creating, giving this to one agency to make it look like a unidimensional problem, nor would it be something that we could solve that way. So we created this independent 501c3 based foundation that is the Colorado Consortium for Prescription Drug Abuse Prevention that has representatives from all these state agencies, and we work in these different 8 work groups to try to move things forward on all of those different areas. And as I mentioned earlier, the Public Awareness Group has this campaign starting. PDMP group is the one that was written into the legislation as being the advisory group to DORA. If you read the new law, that's the consortium still has input to tell DORA what to do to change the PDMP. How do you want to make it better? And any of you can join the consortium today, come to the next PDMP meeting, a work group meeting on March 12th, and tell DORA what to do. And they're obligated by law to listen to you. We have created a situation in Colorado where you can have an input and an impact on it if you just show up. And, we know 90% of getting stuff done is just showing up, right? So that's what we think people should do. Please check the website out. Please volunteer. You can even just sign up for one of these work groups that you're interested in, or just the mailing list, and be kept apprised of things going on. Then you can share those events with your colleagues. That's a start. Just be aware of what's going on and share these events with your colleagues. And maybe if there's thing you're interested in, like this naloxone access, we've had some really wonderful response from some local pharmacies that are getting involved because they're saying, well, how can we go to this, learn about this? How do we start stocking these rescue kits? How do we work on the standing orders? You know, we can have an impact that can immediately start saving lives tomorrow. So get involved at some way at the larger level, even a small amount of your time. And with that, I would be happy to take questions, and thank you very much for your time.
Thank you, Dr. Valak. We're going to start questions with our distance sites. So, good morning, Grand Junction. Does anybody in Grand Junction have any questions for Dr. Valak?
I've asked and I've gotten a lot of head shaking.
You're not getting a lot of head shaking, you said?
Yeah, as in no questions.
No questions. Okay, thank you. We're going to move on to Loveland. And Roberta, you're over in Loveland. Does anybody at your site have any questions?
We're all good here. Thanks.
Thank you, Roberta. Peter, do you guys have any questions in Pueblo?
Yes, we have a question.
Okay.
Joe in Pueblo. I just wanted to know if you make these presentations to the med school, if you work in conjunction with the med school. I mean, if the docs keep writing the medication, you know, the prescriptions for the medications. I know years ago, 1988, I questioned a doctor in Springs, and he faxed me. He says, well, there's new guidelines, and that's when I noticed a big upswing in the prescriptions. And that was from the Society of Addictive Medicine or something, and they had definitions for addiction and things like that. And that's when I saw a big increase in the number of prescriptions written. And we're kind of in a bind if they keep writing the prescriptions. So are you guys working in conjunction with the med school to get these points across?
Yes, thank you. That's a very good question. And yes, we are working with...
You guys have to mute on your end. Peter? We're getting a lot of back feed here.
Okay. Yeah, well, there's a lot we're doing with physicians, of course. This is a huge part of the problem. There's definitely, enough responsibility, shared responsibility to go around. But physicians have their role. The Colorado Medical Society, the Osteopathic Society, the Colorado Academy of Family Physicians are all engaged with the consortium in its work. The CMS has their own prescription drug abuse committee now to work on educational initiatives to try to work with their physician base to provide better education for physicians. We have a provider education group in the consortium that's dealing with those both at the medical school level to teach upstream, but also with continuing education downstream to try to reach providers about these things, which are, again, it's a monumental undertaking to try to, bring up the level of education of all physicians is a big, big thing to try to do. But it's exactly what we're trying to do is to start moving things in that direction of all docs learning more about pain, about pharmacologic treatment of pain, and about this addiction problem. So yes, I've given some version of this talk to 17 different physician groups in the last year. So I will go to any group of physicians, one or more that want to hear it. I will go out and give talks to them and try to help raise awareness.
Are there more questions?
Another question.
Jim Zello in Pueblo. I had recently read an online article about a correlation between the use of marijuana and the decrease in opioid overdose. Have you seen that as well?
Yes, I saw that study, and people are just, obviously we're very interested in that, and we're discussing it. It's the early studies that we're seeing are correlational, meaning you see some uptick here in one thing, and you see a downtick in something else. And those are very difficult to attribute what is causing what, because there could be a pre-existing downward trend, which we have been seeing in the opioid-related deaths in Colorado over the last 3 years. So it may look like that the increased use of marijuana is sort of riding on the coattails of a change that was already happening. So there's a lot of debate because it's very difficult to create a randomized controlled trial about which state is going to have which laws and which state isn't to answer the question definitively. But we are starting to see some of these association data, and that's what people are discussing and trying to figure out is what do those data mean? Does it really mean that that's causing a reduction? That's a hypothesis that people certainly have, but we don't know right now. And again, the data are also very early. 1 year of a data point like that does not make a line yet. We need to see several points connected before we can decide that it's a trend and then try to attribute causes to the trend. But it's certainly very intriguing, and we obviously are one of the few states, one of the few places in the world where we have an opportunity to try to study these things together. Great
Are there
question.
any last questions over in Pueblo?
Okay, no more questions.
Thank you very much. Now, if anyone has any questions here, if you want to come to these microphones, we have 2 in the front. That would probably be best if anybody has any questions here.
Hi, Dr. Valak.
Hi
Good
there.
talk. Thank you. I actually have 2 questions. So the first one is, what specific technologies, if any, do you know are being developed for more safe storage of opioids in the home?
That's a very good question. There are many technologies available. Various forms, most of them take the form of some sort of secure box for putting opioids in. And there's a number of them that are hitting the market now. Some of them you can bolt down to a counter. Some you don't have to. It's just such a secure box that you cannot break into it without having either the tumbler locks to get in or knowing the code. So that they're very secure, like an almost impenetrable little case at least, so no one can get into it without, like the ATM kind of security. Not impossible, but very difficult to get into, and it would stop most of the quick grab kinds of things that we're trying to avoid, because that's what most of it really is. It's not people coming into your house with a sledgehammer to break the door down. It's coming in quickly saying, hey, can I use the restroom? And if something is there, people grab it. And it will stop most of that to use one of these existing technologies. So there's a number of them. If you look for things like medication safe on the internet, of course, just Google it. You'll see a whole bunch of products available.
Okay, thank you. And I personally work in the hospice setting where a lot of opioids are used for not only pain but shortness of breath. And there are a lot of cases, probably more than we realize, of diversion in this setting, not from patients, but from family members and caregivers. What are your comments and thoughts on that? And if you have any potential ideas for addressing the issue?
Yeah, diversion is also, of course, an important topic because of the appeal of the drugs, both themselves and the market for them, for either the individual or to be able to sell them. So the thing we're trying to continue to beat the drum of is security and safe storage. Some places will have dispensing machines or secure carts or whatever it might be to try to control the distribution of those drugs and control access to them, make sure patients get them when they need them, but to try to keep them in some way locked up so that those who don't get a hold of them. It's hard. There's still going to always be a few cracks, but we're trying to fill in as many cracks as we can.
Thank you.
Thanks.
Hi, I was wondering, it seems as if the REMS programs, at least at first blush, are kind of missing from the consortium. And I was wondering if that was an active decision, because there's obviously the shared REMS for long-acting and then TIF REMS, and arguably not sure what impact they're having, but the manufacturers are needed to see what impact. So.
Exactly. No, and the REMS programs are a very important component of this, and it's kind of an FDA manufacturer side thing. And when the consortium folks, during the strategic planning process got together, it was tried to decide, what are the things we think we can do in the short term, in a year or 2 years, that we think we can use these strategies to try to start moving the needle in the right direction. And it was, we picked, probably half a dozen areas that's now expanded to 7 or 8, but that certainly doesn't mean there's not areas that we're not covering. There's a lot of other things with treatment and post-incarceration, which is very high risk, or increasing access to treatment and SBIRT and screening and things that we need to be doing and reaching out to, middle schools and high schools where a lot of this starts, and law enforcement and REMS programs that we're not doing. It's kind of a function, I think, of 50 things we can be doing, and we picked 5 or 6 to start with, and we certainly need to do more.
Thank you.
Thanks.
Hi, Dr. Bellick. My question is a simple one, and I've had some issues with this recently. I'm just wondering if you can shed some light on some resources that are available to us as pharmacists if we identify a prescriber who is either overprescribing or is blatantly misprescribing pain medications, what we can do to rectify that problem.
Yep, that's a very good question. If you're identifying a prescriber that you think may be problematic, I would contact the medical, contact DORA, the Board of Medicine. They want to hear about it, and they don't take the standpoint of going in, guilty until presumed innocent, or presumed guilty until proven innocent. They don't. They go in saying, well, what is this? We'll investigate any issue and look at this to see if the person really is prescribing reasonably or not. And it's basically a group of their peers that are very diligent in doing it. So I wouldn't be afraid to talk to DORA, nor would I be afraid to call the Colorado Medical Society and say, look, what do I do with a potential issue with a physician that I'm not sure about their prescribing practices? How can I get some help? And each of those groups is very willing to talk. And I think people, at one level, yeah, I can report them to the medical board, but all it takes is a phone call or filling out a form, and it starts a process. And again, it's anonymous on the process as far as reporting, unless something gets way down the road where someone's going to get to the point where someone might have their license acted upon. But early stage stuff like that, it's just information and you can talk to them. Can call DEA if you think it's really bad. If you think there's diversion, if you think it's at that level, that someone may be, boy, this is so bad that what I think it has to be is somebody's trying to, participate in some sort of pill mill or something, then you could call DEA. Thanks very much. Appreciate it.